and exams. And after the exams, they realize that the student is having leukocytosis. Now, what is leukocytosis? It's just basically the increase of what? White blood cells. Okay, so they took the blood and counted the white blood cell, and they realized that it is high. So why was it high? But first of all, what are the causes of high blood, white blood cells in the blood? High white blood cells in the blood. So we have two major causes. We have the physiological one, and we have the pathological.
More autofocus.
Pathological. Okay. So sometimes the focusing will be an issue, but after I'm done, I'll just try and adjust it for you. Is it clearer now?
Better now. It's better.
So when we talk about the pathological, these are due to disease conditions. Okay, so disease conditions or ill health states. Okay. Now, physiological means that in the normal process in the body, there can be increase in leukocytosis, and it is normal. There is no disease process going on, but it's just how the body functions in order to get the body prepared for certain events. For instance, so in the physiological one, and we have what we call redistribution of white blood cells. So with the redistribution of white blood cells, it means that in this patient who is experiencing physiological leukocytosis, they are not ill, but just that there are some white blood cells which ideally wasn't in the normal blood flow, but now has managed to get into the normal blood flow. Okay? So this is the patient's blood vessel. This is how the blood is flowing. Okay? So we have two types of blood flow. We have the flow that is found in the middle, and we have the flow that is close to the vessel endothelium, or the wall of the vessel. So the ones that are flowing in the middle, normally when you enter into somebody's vessel, vein or blood vessel, you take the blood that flows in the middle, okay? So that flow is called axial flow. And the ones, the blood that are close to the wall of the vessel, we call it the marginal flow, okay? The blood flowing close to the wall of the vessel, we call it marginal flow. All right. So normally, what happens is that when you take somebody's blood, you take it from the axial flow. People who are having physiological leukocytosis, in the marginal flow, we have some of the white blood cells flowing over there. So it means that, and we have some of the white blood cells flowing in the axial flow. So it means if you are taking so we have 4 of them, so let's just use 4 as an example. If you are taking the blood from this particular vessel, you are taking it from the axial flow. So assuming we are taking all this blood, it means that once we take the blood from the axial flow, we will get what? 4 of the white blood cells being taken from the axial flow. But these 4 found in the marginal flow will not be part of the ones that you draw from the patient vessel. However, in some physiological states, example, when the person has finished eating, or when a person is undergoing stressful event, okay? Stressful event. What happens is that not only the marginal flow, but even white blood cells stored in the bone marrow is going to move from the marginal flow, from the bone marrow, from other lymphoid tissues, and get into the axial flow, okay? So the marginal flow and bone marrow and other lymphoid tissue like the spleen, okay? They will all move and join the axial flow. So in physiological condition like stress, like after meal, maybe exercise, yes, pregnancy states, newborns, first 2 days after newborn, okay? First 2 days of the newborn. These are the physiological states. In this stage, the patient is not ill, okay? But because they found themselves in this state, their white blood cell count is increasing. And how does it increase? It is not because the bone marrow is producing new white blood cell. These white blood cells, which is being seen as increase, are already produced white blood cells. But those white blood cells are not part of the marginal flow. They are either found on the marginal, they are not part of the axial flow, but they are either found on the marginal flow or the bone marrow or the spleen. So in a stressful condition or in newborns or after meal or after exercise, these white blood cells can now move from the marginal flow, from the bone marrow, from the spleen, and join the axial flow, and then increase the number of white blood cells found in the axial flow. And I said that normally when you are taking blood from the person's vessel, it's the axial flow blood that you are taking. So it's because there is redistribution of the white blood cell from the bone marrow or the spleen or the marginal flow into the axial flow. That is causing the increase in the white blood cell count, which is called leukocytosis. And the process by which these white blood cells move from these depots, so the marginal flow and the bone marrow or the spleen together, we call them the white blood cell depot. It's called redistribution. So when the patient finds themselves in a stressful condition, normally they produce epinephrine and norepinephrine, okay? And it is this epinephrine and norepinephrine that will cause the redistribution of the white blood cells from their depot into the axial flow. And once you take the person's blood, the white blood cell count will go up. Does anybody have any question? So looking at this, the student was writing an exam, and we all know that exams writing is a stressful state. So the patient will definitely produce a lot of epinephrine and norepinephrine, okay? Norepinephrine. Norepinephrine. And that will cause the movement of white blood cells from their depots. The depots are bone marrow, spleen, marginal flow. Then they will get into the axial flow. And it's the axial flow blood that we usually take for exams. Does anybody have any question? So in a stressful condition like after exams, and if the patient white blood cell increases, it is because there's redistribution of the white blood cell into the axial flow.
Okay.
Yes, sir.
So please, my question is, so what role are the catecholamines, that is the non-epinephrine and the epinephrine? What role do they play?
So you want to know exactly how they cause the white blood cell to?
Yes, please. Yes, please.
So normally there are some cells that we call the myoepithelial cells.
Yes.
Okay.
Yes, sir.
We have some cells, for instance, in the spleen, there are cells which contains kind of they are like they contain some myofibrils. Those myofibrils are like those fibrils found in muscles, okay? Mm-hmm. So what they do is that they go there, act on the myoepithelial cells, and these myoepithelial cells somehow will contract. And once they contract, they move the white blood cells from those depots, okay? Okay. And so that's the function of the epinephrine and norepinephrine. So they will act on the depots to cause the white blood cells to move out of that place and join the axial flow.
Okay.
Yeah. Is there any other question again, or we should move on? So please, I want you to remember this. There are two types of leukocytosis, physiological and pathological. Pathological is when the patient is sick, okay? Physiological is when the patient is not sick, but the patient finds themselves in a particular physiological state. Because if you eat, you are not sick. If you're exercising, you are not sick. But just that your body is functioning normal in a different setting. So in the physiological one, it is not because the bone marrow, you see, normally the bone marrow produces the white blood cells. People who are sick, there is some cytokines that are produced and sent to the bone marrow to start producing new white blood cells. So in the disease or the pathological state, there will be production of new white blood cells. But in the physiological state, there is no production of new white blood cells. But these white blood cells are already produced matured blood cells, which are stored in various areas in the body. So that when maybe the person finds themselves in a particular physiological state like pregnancy, stress, or maybe after meal, these white blood cells jump into the axial flow and increases the white blood cell count in the blood. So normally those white blood cells in physiological states, those white blood cells that you see are actually all matured white blood cells. And when you see it like that, that is what they normally call right shift, okay? Right shift. I think you might have come across the word left shift and right shift, okay? So in physiological state, it will lead to that right shift. And in the pathological state, normally most of them will lead to left shift, okay? So let's move on to the next question. Okay, so Mr. Alfari, can you please read the second question for us?
Yes, sir. A patient was stung by a bee. A bee. Oh, okay. By a bee.
Yes.
Examination revealed that his left hand was hot. His left hand was hot. Oh, this thing.
The left hand was
what? Hot. Was hot. And then edematic. There was a big red blister on the site of sting. What is the leading mechanism of edema development?
All right. So please give me a bigger screen. All right. So this patient was stung by a bee. So when the bee bit the person, the site where the bee bit became hot, it became pink, it became edematic, okay? So pink here can be redness, right? Edema, okay? And obviously probably the patient will experience skin, okay? And these are all signs of what? Inflammation. So it means an inflammatory process was going on. But they want to find out why the patient had the edema, okay? Now, almost every part of our body is having some type of connective tissue called the areola. It's a loose connective tissue, areolar connective tissue, okay? Connective tissue. Now, the cells that makes up this connective tissue. So normally, when you hear connective tissue, think about ground substance, think about cells, and think about fibers, okay? So the cells that usually make up this areolar connective tissue, we have mast cells. Mast cells forms majority of those cells that are found in the areolar connective tissue. But because this areolar connective tissue is found almost every part of our body, it helps in the inflammatory process. And it is good so that the mast cell can get a place to reside. So if there is a damage going on in our body, the mast cell will quickly react. But look, the patient had a bee sting. When the bee bit the person, this is what is going to happen. It is going to introduce some proteinous substance, like those proteinous substance will directly, listen, it will directly stimulate the mast cell. And you know, the mast cell is a cell containing, it's an immune cell though. It is containing granules, and these granules are having histamine in it. Okay? Normally, this mast cell, it has two ways of being stimulated. One way is that it is also having an immunoglobulin E, okay, on it. That's when a particular antigen stimulates the binding site. This functional site will cause the granules to degranulate. But then there are other substances that can directly stimulate the mast cells. And in case of the bee sting, it can either directly stimulate the mast cell or indirectly stimulate the mast cell by first binding to the immunoglobulin E. So if that was the first time the person got bitten by the bee, okay, what will happen is that this mast cell will be directly stimulated, and then these granules will come and fuse with the membrane and release all the histamine. Remember, the granules in there is histamine. It's containing histamine. So it will release this histamine to the site of bite. And once this histamine is released, you know, there are a lot of capillaries, distribution of capillaries and other vessels around. So that what is going to happen is that first, there is a bite, and it is an injurious process going on. So the mast cell will come there, release the histamine, and try to dilate the blood vessels over there, so that if there is a foreign or a microbe coming there, more white blood cells can pass through the vessels and fight against it. That is how it is programmed to behave. But this one, the proteinous substance, will directly stimulate the mast cell, and the mast cell will release the histamine, and this histamine will first dilate the vessels, okay? So normally it's not only histamine, it has bradykinins, serotonins, and other stuff. But in this case, it's the histamine that is very important. So first, the vessels over there, the capillary vessels or whatever, will be dilated. And once they are dilated, those endothelial cells, you know, the capillary vessels, they are made up of endothelial cells and just a basement membrane. So normally, the endothelial cells are closely attaching to each other. Okay, there are no gaps in between them. They are attached to each other. So first of all, the histamine will cause the dilatation of the vessel. And secondly, it will increase the permeability of this capillary vessel. How? There are two ways. One is what we call retraction. Okay, so in the retraction, just the edges, okay, which was first forming that tight junction between each and every endothelial cells, will just move away a little, okay? Just the edges move away a little, and then there will be some spaces between them, okay? Why do you think there should be increase in permeability? Remember I said that first histamine will come there, dilate the vessel, and probably some white blood cell will come here, okay? Now the white blood cell, once it gets to the site of histamine release, where the histamine is released is where the damaging is occurring. So once it gets to the site of histamine release, it has to find a way of getting out of the vessel. So the histamine again will cause retraction of the endothelial cells, okay? Because the endothelial cells is having some actin fibrils, and it will act on it to cause the retraction. So once the retraction occurs, now these white blood cells can leave, okay? It can leave through those spaces. Now, once there is opening there, because this vessel is carrying blood, which is liquid in nature, the liquid form, which is the plasma, okay, some of it will start seeping out of these small opening, okay, and accumulate at the site of injury. And because there is fluid moving out of the vessel, plus some white blood cells moving to the site of injury, that place will become what? Swollen. Okay? So, one, the most important thing you should understand is that when it comes to the edema, in other terms is to the swelling that we are talking about. The edema occurred basically because there was retraction. And because there was retraction, permeability within the vessel had increased. So fluid can now seep out of the blood vessel and get to the surrounding. Okay? Does anybody have any question? So the patient was bitten by a bee. The proteinous substance or the venom that the bee released caused the histamine release from the mast cells. And the histamine in turn dilated and also increased the permeability of the capillaries around the area of bite. And then because there is increased permeability, fluid can now seep out of the vessel and then cause edema. So the edema is because there is increase in spaces between the endothelial cells, and that is what we call increase in permeability. Does anybody have any questions? All right, so let's move on to the next question. Okay, Daphne, can you please read that question for us? So this question, the answer was increase in vessel permeability.
Okay, number 3, a patient caught a cold after which they appeared facial expression disorder. He cannot close his eyes, raise his eyebrows, bare his teeth. What nerve is damaged?
All right. So with this question, there are 2 ways, the shortest way to know what the answer is. The simplest way is to know which nerve controls the facial muscles, okay? So the nerve that controls the facial muscle are a simple facial nerve, okay? Who can tell me the number of, the cranial number of facial nerve?
7.
I think 7.
7, thank you. Thank you very much. Now, so the nerve that controls the facial muscles is facial nerve, okay? Facial nerve. Who can tell me another function of facial nerve? Apart from controlling facial muscles. Okay?
Okay, it can also be found in the 1/3 part of the tongue, which is used.
Anterior what? 2/3, not 1/3, right?
2/3 of the tongue.
So it will taste also, right?
Yeah, taste.
Okay. So anterior what? 2/3. Who can tell me another function? Anterior 2/3 of the tongue. Okay? Okay, who can tell me a parasympathetic activity of the facial nerve? So when you feel sad or when something pains you or maybe when someone breaks your heart, what happens? Become sad and you do what? You cry, right? You cry. So the lacrimal gland, okay? The facial nerve is having a parasympathetic branch called the petrosal, the greater petrosal nerve, okay? That's the greater petrosal nerve. Now pay attention here, petrosal nerve, okay? That's the parasympathetic branch of the facial nerve, which controls the lacrimal gland, okay? Now, in the facial bone, there is an area called the pterygopalatine. Pterygopalatine fossa. Okay, so it's a cavity. And over there, in that cavity, there is a particular ganglion, okay? There. You know, ganglion is just a connective tissue surrounding group of cell bodies, right? So it means that there are different cell bodies passing there. Now, one of the cells that pass there is the parasympathetic branch of the facial nerve called the greater petrosal nerve. That greater petrosal nerve supplies the lacrimal gland and also supplies the nasal mucosa. The nasal what? Mucosa. Okay? So you know the nasal mucosa is made up of a lot of goblet cells and it produces mucus, right?
Image.
Yes, so you have the image there, right? I just want to clarify I just want to clarify certain things, then I'll use the image to give you the explanation. So first of all, we have facial nerve. The facial nerve, we have some functions here. We said it controls the facial muscle. It controls taste. So it is both what? Sensory and what? Motor nerve, right? So it carries sensation of taste from the anterior two-thirds of the tongue. It also has a parasympathetic role by controlling the lacrimal gland using its greater petrosal nerve, right? And that greater petrosal nerve also supplies to the nasal mucosa. Now look at something. Because this greater petrosal nerve is supplying the nasal mucosa and it is still connected to the facial nerve, when there is a problem in the nasal mucosa, what will happen is that if it is an infection and it is damaging the nerve can go retrospectively and destroy the facial nerve also, or affect the facial nerve also. I hope you understand it. So, if in your nasal mucosa, if you are having a condition like rhinitis, okay, rhinitis or any of the flu, what is going to happen is that because the greater petrosal nerve is supplying the nasal mucosa, that infection can go back retrospectively to the facial nerve and have an effect on it. So let's look at the image that we have here so that you understand it from that point. So, unfortunately, I cannot control the distance from here, the cursor from here. But if you look at the upper left corner, there is a facial nerve, right? There's a facial nerve over there. Now, the facial nerve will first pass through that geniculate ganglion. That's not what we are interested in. But you realize that that facial nerve will come downwards, passing through that canal, okay? That canal is usually the auditory canal. So it will pass through that internal auditory canal, the internal auditory canal. So it will pass through that canal, get to the middle ear, and then give a branch from the promontory. Maybe you may not be clear with what I'm saying, but there is a nerve coming from the facial nerve. Then once it gets to the pterygopalatine ganglion, it will give a branch to what we call the greater petrosal nerve that will go to the upper right corner. What structure is there? The lacrimal what? That, right? Or the lacrimal gland, the lacrimal gland. And from that same pterygopalatine ganglion, a branch of the greater petrosal nerve will go to the nasal mucosa, right? So in case there is a rhinitis or a flu, the infection can travel back from the nasal mucosa back to the pterygopalatine ganglion, then back to the facial nerve, and then cause dysfunction of the facial nerve. So in this case, the patient's facial nerve may not function properly, and the patient's facial muscles may also not function properly. And other, what do we call it? Other function of the facial nerve too may be affected, okay? Does anybody have any question?
Yeah, my question is like, I want to know the difference between the infraorbital and the facial nerve.
You said you want to know what?
Difference between the infraorbital nerve and the facial nerve.
The infraorbital nerve.
Yeah.
Please give me the picture again. You said you want to know the difference between which one? The infraorbital nerve.
Yeah, yes, yes.
Where is the infraorbital nerve? Or the infraorbital nerve is not here?
No, it's not here. It's not here.
Because facial nerve is a cranial nerve, right? The infraorbital nerve, I'm not really sure.
It has nothing to do with the facial nerve. You understand? Infraorbital nerve is part of trigeminal nerve.
Which one is he talking about?
He's talking about infraorbital nerve.
But if you look at the trigeminal nerve branches, we don't have, okay, you are talking about the branch of the
Maxillary nerve, yeah, it's a branch of the maxillary.
Yes.
Yeah, that's
Okay.
So it has nothing to do with the facial nerve.
It has nothing to do with the facial nerve, but it is also another, what do we call it? A cranial nerve that supplies the face for pain, temperature, touch, and sensation, the trigeminal nerve.
Mm-hmm.
Okay, I get it now. Thank you.
Or you have something to say?
No, I get it now. I get it now.
All right. So basically, this one wants you to know that there is a link between the nasal mucosa and the facial nerve, okay? All right, so let's move on to the next question.
So Dr. Mo, the answer is ye, right?
So the answer, let's read the question again and answer it. So the answer is going to be the facial nerve, okay? I don't know whether it's C or B or
Okay.
So listen, they said a patient caught a cold, after which there appeared facial expression disorder. He cannot close his eyes, raise his eyebrow, bare his teeth. What nerve is damaged? So here the answer is 1. He cannot close his eyes or raise the eyebrow. Those are facial muscles activity. So first,
Okay.
you know that is the facial nerve that does that, okay?
Oh,
But
okay.
I brought the other functions of the facial nerve, like taste and lacrimal gland, because there are some other questions where they will say the patient can no longer produce tears and loss of taste and stuff like that, okay?
Oh, okay.
So that you know that it's the same thing that we are talking about.
Oh, okay.
All right. So Gloria, can you please read question number 4 for us?
A newborn child has convulsions that have been observed after prescription of vitamin B6. This most probable cause of this effect is that vitamin B6 is a component of the following enzyme.
All right. So when someone is having convulsion, okay, it means that there's uncoordinated electrical impulse activity. Okay, so there is uncoordinated firing of electrical impulse reaching the brain, but because they are uncoordinated, it leads to uncoordinated muscle contraction and relaxation, and that leads to convulsion, right? So, normally in our brain, there is a neurotransmitter which will reduce the rate at which certain impulses are being conducted, right? And it's GABA. So GABA is an inhibitory neurotransmitter. Inhibitory neurotransmitter. So, like I said, if there is an uncoordinated electrical activity getting into the brain, okay, so there will be another.
The screen is not clear, sir.
Okay, I'll make it clear, okay?
Okay.
Is it clear now?
No, Dr. Mo, it's very blurred.
Is
It's
it
not
okay?
focused.
All right.
Yeah.
Is it better now?
Yes.
Yeah.
All right. So this is neural cell 1, neural cell 2, right? Normally there is stimulation here, and then the information will be transferred this way. Once it gets to the axon knob, so this is the cell body, this is the axon, and this is the axon knob. Once it gets to the axon knob here, there is release of substances which will communicate with the next cell. So this connection between the axon and the dendrite, so this is the dendrite of the second nerve, it's called synapse, okay? It's called synapse. Now here, there is release of substances that will help the communication between the first cell and the second cell. And those substances usually are neurotransmitters, okay? Some of the neurotransmitters will allow the information to go on. Some of the neurotransmitters, probably there is an information going on here, and it will stop that information from going on again. So the ones that will allow the information to go on still is called excitatory. Excitatory neurotransmitters. And the ones that will stop or inhibit the further transmission of information is called inhibitory. Now, we are basically talking about the inhibitory one, and this inhibitory one example is GABA. Now, what GABA does is that it will bind to a receptor and then open some ion channels. And those ion channels are usually chloride ion channels. Once this chloride gets inside, then it inhibits the second neurotransmitter. So it's quite simple. GABA will bind to each receptor, and then ion channels will open, and chloride will come inside and cause inhibition. Okay? So maybe as we go along, I'll explain much about the, what we call it, the physiology of this neurotransmission, okay? Membrane physiology. Now, it means that GABA is very important if there is excess activity or excess transmission of impulse. So if these impulses are going on and on and on and on uncoordinatedly, there will be uncoordinated muscle contraction and relaxation. That is called convulsion, right? And for you to be able to stop the convulsion, you have to give either GABA or a drug that behaves like GABA. So some drugs like diazepam behaves like GABA, okay? Drugs like phenobarbital or barbiturate, they all behave like GABA, even though from different mechanisms. So the GABA is the naturally produced one. These ones are the artificial ones, okay? So if someone is continuously having convulsion, it's either the person wasn't producing enough GABA, okay? Or probably there is some condition that has led to excess impulse transmission. So in a child, in this child, they are saying that this child was lacking an enzyme called B6. Sorry, a vitamin called B6. Now, this vitamin called B6, yesterday we spoke about it, that is called what? Pyridoxine, right? Pyridoxine. Okay, it is actually a cofactor or a coenzyme. So it acts as a coenzyme so that there can be production of GABA. So we know that GABA helps prevent convulsion. But if there is no GABA, convulsion can occur. But we want to see exactly how GABA is produced. GABA is usually produced from an amino acid called glutamate or glutamic acid, right? So glutamate will be converted to GABA through a process called decarboxylation. Now, decarboxylation basically means that because this one is an acid, you know, the carboxyl group makes it an acid. So what will happen is that decarboxylation process is a process whereby those carboxyl group will be taken away from the amino acid, okay? Then we'll get GABA, okay? And that carboxyl group will go out as carbon dioxide. Now, so we are going to see how glutamic acid is used to form GABA. So it's a good decarboxylation process, and the name of the enzyme that will catalyze that process is called glutamate decarboxylase. Okay, decarboxylase. Now, this is the enzyme, but this enzyme needs a coenzyme in order to function properly. And that coenzyme is called, we usually call it pyridoxal phosphate. Okay, we call it pyridoxal, or they call it simply PLP. So what are we talking about? We are saying that GABA helps in preventing convulsion, and it means that, and GABA is produced naturally from amino acid called glutamate or glutamic acid. And the process by which glutamate can be converted to GABA is called decarboxylation. And the enzyme that catalyzes that process is called glutamate decarboxylase. And this glutamate decarboxylase, so let me make it simple here, since it's too crowded. So we have an amino acid called glutamate, right? And this glutamate is going to be used to produce GABA. GABA is anticonvulsant, okay? Anticonvulsant. Just look at it from that point of view. So if you don't have GABA, you convulse. So a baby was born, and they are saying the baby lacks an enzyme called B6. But we are saying that we will now come and arrive at here. Glutamate has to be converted to GABA. The enzyme converting glutamate to GABA is called glutamate decarboxylase. This enzyme cannot work alone. It needs a push, okay? It needs something to push it. And the name of that to push it is PLP, which we call the pyridoxal phosphate, okay? So this whole process is called decarboxylation. Decarboxylation. And I said there will be production of what? Carbon dioxide. So carbon dioxide will be produced. GABA is needed as an anticonvulsant. This is how naturally the body produces GABA. glutamate is converted to GABA in the presence of glutamate decarboxylase and PLP. PLP is what is taken from, that's the active form of B6. So if the child was lacking B6, it means that glutamate decarboxylase cannot work well. And if glutamate decarboxylase cannot work well, glutamate cannot be converted to GABA. So it means lack of B6 can lead to excess, there will be no production of GABA. So if there is no production of GABA, there will be what? Convulsion. Okay? Then what? Convulsion. So no GABA, it will lead to what? Convulsion. Does anybody have any question? All right, so let's move on to the next question.
Hold on 1 minute.
So, Dr. Mo, what is the answer?
So read the question again. And Mr. Afari, you answer it for me. I hope you understand. You understand what I...
Very well.
Okay, thank you. Umar, lower the volume. So, Mr. Afari, they are saying a newborn child has convulsions that have been observed after prescription of vitamin B6. This most probably cause of this effect is the vitamin B6 is the component of what's the wait.
Okay.
A newborn child has convulsions that have been observed after prescription of vitamin B6. This most probably cause of this effect is that vitamin B6 is a component of the following enzyme. And the answer is going to be
glutamate decarboxylase.
Glutamate decarboxylase.
Yes, but the question, I don't like the way they phrased it.
Yes, yes.
Okay. So, Emmanuel, can you please read question number 5 for us?
Okay. Number 5. Bacterioscopic examination of a smear from the pharynx of a diphtheria suspect revealed bacilli with volatile granules. What ethiotropic drug should be chosen in this case?
All right. So, first of all, this patient, we know that the patient they are suspecting that the patient is having what? Diphtheria. And when they did a smear from the pharynx, they found a bacilli with volatile granules. And that describes the causative agent of diphtheria. Okay? The causative agent of diphtheria is what? Corynebacterium diphtheria, right? So the Corynebacterium diphtheria is having an external knobs like that, okay? And that is what we call the volatile granules. It looks like this, okay? But you know, it is not the C. diphtheria that usually causes the diphtheria. The presence alone doesn't mean the person is suffering from diphtheria. The C. diphtheria has to undergo a process called phage conversion, okay? Phage conversion. And this phage conversion would, listen very well. Most people who are healthy, you can take a smear from their throats and you can still identify C. diphtheria. Now, when you see that C. diphtheria is in the patient's throat, that doesn't automatically mean the patient is suffering from diphtheria. That bacteria may be there, but may not be causing diphtheria, because before the bacteria can cause diphtheria, it has to undergo what we call phage conversion. It is in the Krok, so phage conversion, or T or something like that. Now, this phage conversion, what is happening is that a virus called bacteriophage, okay, bacteriophage will introduce a DNA part which will cause some mutation in the diphtheria to start producing certain toxins, okay? Certain toxins. So it is only when the C. diphtheria has undergone phage conversion, because the bacteriophage altered it, right? And then from there, this C. diphtheria will start producing these toxins. Now it is this toxin that causes the diphtheria, okay? So it is this toxin that will start destroying the mucous membranes and stuff like that. So these toxins here can be proteinous in nature, okay? And once they are proteinous in nature, it means that they can stimulate the production of what? Antibodies. So it means someone who is having diphtheria can produce some antibodies against the toxins, right? So for people who are having the condition for the first time, they don't have the antibodies. So scientists took these toxins, injected it in another animal, and the animal started producing the antibodies against these toxins. And that antibody is called antidiphtheric serum, because the serum is in the serum that you can get the antibodies, okay? So this antidiphtheric serum or this antidiphtheric antitoxin, okay, basically it's an antibody, okay? These are antibodies against the toxins, okay? Against the toxins. Now, listen very well. They took this toxin, injected it into another animal, and that animal's immune system started producing, or they used a laboratory method, okay? Because now we have the E. coli used to produce certain things, okay? They use some laboratory method to get antibodies being produced against these toxins. And those antibodies are called antidiphtheric serum or antidiphtheric antitoxin. So it means that these antibodies, if someone is suffering from diphtheria, you can just inject the person with this antidiphtheric antitoxin to treat the diphtheria. Since the diphtheria is caused by the toxins produced by the C. diphtheria. I hope you understand. Now, don't get confused with the diphtheria and a toxin. Okay? There is difference between the antitoxin and the anatoxin. See, basically the anatoxin is this toxin that they've taken. Normally the toxins do have the active part and the binding side. Okay, the A part and the B part. The active part is what causes the disease. But the B part here is the one that can stimulate the immune system to produce antibodies. So normally they will take the toxins of the diphtheria toxin, and then they will destroy the active part which can cause the disease and leave the B part. So it is this B part that you can inject it in a healthy person. A healthy person, so that the body of that healthy person will start producing antibodies. But since the A part is not there, the patient will not suffer from the disease, but rather the patient will benefit by the B part stimulating the immune system to produce these antibodies. Hope you understand the difference between the anatoxin and the antitoxin, antidiphtheric antitoxin. Does anybody have any question? Does anybody have any question?
No.
All right, so
Dr.
let's.
Mo, please,
Yes.
can you come again with the anatoxin?
Okay. So what I'm saying is that The diphtheria, okay, diphtheria is the disease. The bacteria that causes diphtheria is called Corynebacterium diphtheria, okay?
Yeah.
Disease name is called diphtheria, okay? So this is the disease. Bacteria, the bacteria causing it is called Corynebacterium diphtheria. So C diphtheria, okay? Now, this bacteria produces a toxin, okay? And that toxin is what actually causes the disease, diphtheria, okay? I just said something here so that you understand it better. I said that normally the Corynebacterium diphtheria does not produce the toxin, but after it has undergone what we call phage conversion, okay? Phage conversion, something called bacteriophage will alter this bacteria to start producing the toxin. And the bacteriophage altering the bacteria to produce toxin, the process is called phage conversion, okay? And once these toxins are produced, these toxins will cause the disease called what? Diphtheria. So, how do we treat this diphtheria? We give something that can destroy this toxin, okay? And what we give to destroy these toxins are antibodies against this toxin, okay? And these antibodies are called anti-diphtheric antitoxin, okay? Or maybe they will say serum, okay? And what I'm saying is that this is the drug that we use to treat the condition called diphtheria. So this is the drug for treatment, okay? So when they ask you etiotropic means causative, okay? The causative treatment. Etiotropic treatment is giving a drug to treat the cause of the condition. So in this case, you are going to give this drug to treat the condition. But I was telling you that don't get confused with the diphtheria anatoxin. Okay, diphtheria anatoxin. This anatoxin here, we use it for vaccination. Okay, we use it for what? Vaccination. This anti-diphtheric antitoxin, we use it for what? Treatment. And I was trying to explain to you what the anatoxin is. The anatoxin is the toxin part of the toxin that the diphtheria has produced, all right. But that toxin is having A part and the B part. So just take the A to be the active part and the B to be the binding part. This B helps in the production of antibodies, okay? And this A will help in the causing of the disease, okay? Now, so what will happen is that when the scientists take this toxin, they will just take away the parts that will help the body to, or that will cause the disease in the body, and leave the parts that will help the body to produce the antibodies, so that they will give this B part alone. This B part alone is what we call the anatoxin. And once you give it, that process of giving that injection to healthy people is called vaccination. We give it so that the patient naturally will be able to produce these antibodies, so that the patient will no longer suffer from the disease.
Oh, okay.
Do you understand it now?
Yes, yes.
Okay. Now let's move on to the next question, please. Okay, so someone is using an iPhone. Please try and always use their name, okay? Okay, Kathy, can you please read the answer to that question was anti-diphtheric toxic serum, okay? Okay.
Okay.
So read question number 6 for us.
Yes, sir. A patient has decreased vasopressin synthesis that causes polyuria and as a result of it, evident organism dehydration. What is the mechanism of polyuria development?
All right. So they are saying that the patient had a decreased vasopressin synthesis. So what's the other name for vasopressin?
Antidiuretic hormone.
ADH.
ADH, antidiuretic hormone. Thank you. And it's produced from which part of the brain?
That is it.
Anterior.
From the anterior.
The posterior.
Posterior. Very much. It's
Posterior.
the posterior. What's the other name for posterior pituitary gland? Neurohypophysis. Neurohypophysis. Okay.
Okay. Antidiuretic.
So you need to know all the other names for the structures, so that they don't trick you with it. So I'll draw something small here. This is the thalamus.
Oh, person.
Posterior. The anterior produces about 5 hormones, and the posterior.
So this one here is the posterior, and this one here is the anterior pituitary.
And I'm the new student in a question.
So the posterior pituitary.
Dr. Mohammed, somebody is asking a question.
You said
a question.
Question.
I'm listening.
The neurohypophysis, does it produce the ADH or is a relay center for the ADH?
So it's a relay center for the ADH. That is where it is released. Actually, the ADH is produced from the paraventricular nuclei. Okay, we have paraventricular nuclei, and we have this thing. What do we call it? Supraoptic nuclei. So these are found in the hypothalamus. Okay, and that is where the ADH and vasopressins are produced. But they are just stored in the posterior pituitary gland. Okay, so these ADH are just stored over there, and they are released from the posterior pituitary gland. Okay, so it produces oxytocin and vasopressin. ADH is the same as vasopressin. Okay, now what happens is that normally here in the hypothalamus there are what we call Osmo Receptors, so that whenever your this thing goes up, your osmolarity goes up. Osmolarity, maybe when your salt level goes up, it means you are dehydrated, right? When your salt level in the blood goes up, those cells will send a signal to the posterior pituitary gland to release ADH. And this ADH will come to our kidneys, okay? And what it will tell our kidney is that, okay, you stop. Don't urinate a lot, okay? So urinate small, okay? How? Specifically, you know that we have a nephron in the kidney, like that. It goes down as far proximal convoluted, then descending limb, loop of Henle, ascending limb. Then we have what do we call it? Distal convoluted tube, and then we'll give branches to what? Collecting that. Now, when urine is being formed, okay, ADH will come to this part here, they're collecting that. There are some cells over there which are having receptors for ADH. That receptor is called Vasopressin Receptor, and it's usually V2, okay? V2 receptor. Vasopressin is having more functions than just this, okay? So I'll just mention one of them. Vasopressin, because it causes constriction of vessels, okay? So normally on the vessels we have V1 receptors, so that the vessels can be constricted, okay? But here, this is where it is very, concerning our question, this is where we must pay attention to. These V2 are receptors for ADH. So when the ADH come here, they will bind to that V2 receptor. And once they bind to it, there are some substances or channels, water channels in here. And these water channels in here are called aquaporins. Okay, aquaporins. these aquaporins will now be inserted here. And they will now allow, because first when the urine gets here, they will just go out as urine. But then once ADH is released, it binds to its receptor. These aquaporins are inserted at the apical or the luminal surface of the cells, so that water, instead of it coming out as urine, will pass through the aquaporins, and then it will eventually go back into the vessels surrounding the kidney, and then back into general circulation again. So the function of ADH is to make sure that we don't get so much dehydrated. Okay, so it causes reabsorption of water. ADH, once it releases, it causes reabsorption of water from the collecting tubules. Now, when someone is not releasing ADH from the posterior pituitary gland, then we call that condition diabetes insipidus, but neurogenic diabetes insipidus. It will lead to insipidus. It means that there will be no ADH binding to B2 receptor here. And this, because there is no ADH binding there will be no water reabsorption here. And all the water will come out. Even if you are thirsty, still you urinate plenty. Okay? And urinating plenty due to the lack of ADH is called diabetes insipidus. If the problem is actually coming from the lack of release of ADH, it's called neurogenic. There are situations whereby these B2 receptors will not respond very well to the ADH. And that is, in that case, this same process will occur. Urinating plenty will occur, but in this case, it will not be neurogenic, okay? But that one will be okay? Nephrogenic type, okay? So if there is no release of ADH, there will be what? Reduced reabsorption of water. And if you lack, if you don't reabsorb the water, you urinate all of them away and you still become dehydrated. Does anybody have any question? So let's answer the question and move on, please.
We've exhausted 1 hour so far.
So a patient has a decreased vasopressin synthesis that causes polyuria as a result of its evident organism dehydration. What is the mechanism of polyuria development? So the answer is going to be what? Reduce tubular reabsorption of water. And the answer is going to be D, reduce tubular reabsorption of water. Let's move on to question number 72. All right. So, Millicent, can you please read that question for us?
Okay.
Move your toy to send it inside.
A 62-year-old patient who previously worked as a stalker was admitted to the hospital with a complaint about general weakness, abrupt weight loss, hoarse voice, dyspnea, dry cough. Laryngoscopy revealed a tumor in the pharynx that invaded vocal cord and please, I can't see the rest.
That invaded the vocal cord and epiglottis. Yeah. What is the most probable cause of tumor development? Okay. So they're asking what could have been the cause of the, wait, please, the question again. So they said that the patient was a stoker, okay? And you know, those stokers, I think stoker is those people who work at the railway. You know those years when the railway used to use coal, okay? Please, bigger screen now. You know, previously the trains, they were using coal, okay? And those people who will be fetching the coal and be putting it into the engine and then to burn, and then the rail the train will be moving. Okay. So they said that later this patient developed, basically what they are saying is that the patient had what? Lung cancer. Okay, so what might have caused the cancer? They said that the person is a smoker. And the smoker, their work is to put coal into their destiny. See, those people smoking, okay, those who smoke, those who work with coal, those who are maybe they burn a lot of firewood, okay. I don't know whether that's their work or not, okay. And smoking. And even, you know this, when you fry an oil, when you use an oil to fry maybe your potatoes or whatever, and you use it again and again and again, continuous reheating or reusing of oil, okay, and also crude oil. These substances or these activities lead to the production of what we call polycyclic hydrocarbons, okay? There's like it's something like a benzene ring, okay? A benzene ring. So this is what is gotten from that fumes that are coming from the smoke and the coal and reusing of oil. And these particular substances, the polycyclic hydrocarbons, they are also carcinogenic. Okay, they are also carcinogenic. So these when you're exposed to these polycyclic hydrocarbons for a very long time, they tend to produce certain substances that alter the DNA.
The camera is not that clear.
Can you see it now?
No.
Is it okay?
Yes.
All right. So those people who smoke or work with coal, or maybe for those people who like reusing their oil over and over again, you know, these activities leads to the production of those polycyclic hydrocarbons. And these polycyclic hydrocarbons are carcinogenic. They can cause cancer. Okay, basically what they do is that they actually, once it is lipophilic, okay, so it means it can easily penetrate into our cells. So once they get into our cell, they are converted to another form of byproduct that can alter the DNA. Okay, so mutation can occur and it can lead to cancer. And one of the most common cancers associated with this are the lung cancers. So if you see someone smoking and the person is having a lung cancer, it's most likely that it was polycyclic hydrocarbon that led to the cancer. Okay? So whenever you see a coal or a stoker, or maybe someone who smokes, or maybe someone who works with a chimney or something like that, wherever there is a smoke or burning of firewood and coal and other things, charcoal, then think of polycyclic hydrocarbons production, which can lead to cancer. Please, let's move on to the next question. Does anybody have any question?
So, Dr. Mo, with
Yes.
what you said, how many times can we use this our oil that we've been using for cooking to maybe fry the fish?
Okay.
Like that?
Okay.
Please,
Please,
only once.
That one, they said once.
Oh,
Because they said that it is not a matter of, you see, even the ones, it depends on how long you are even using it because of the level of heating. Okay? So the answer is going to go at polycyclic aromatic carbohydrate, but it's the same as the hydrocarbons. Okay? So please, let's move on to question number 8. Bright, can you please read that question for us?
Okay, a patient who suffer from severe diabetes and don't receive insulin have metabolic acidosis. This is caused by increased concentration of the following metabolites.
All right, so please, bigger screen. Let me explain something small here. So you know what? Once you are hungry, first of all, when you eat, okay, when you eat and you are very full, some of the the food will first be converted to glucose, and once the glucose level in your blood is okay, the brain has taken its portion, then the excess will be stored in the liver, okay, as what? Glycogen. Now, so after eating, that is after eating, right? Now, whenever you finish eating and then excess glucose is stored as glycogen, then when you are not eating for some few hours, okay, this glycogen can break down back into what? Glucose. So that the brain is the most important part. The brain will keep on getting constant supply of glucose for its activity, because the main source of energy for the brain is glucose. But then when there is no glycogen there again, okay, when there is no glycogen there again, it means that the glucose cannot be gotten from the liver again. So there has to be a way that the body can still produce glucose, so that the brain can still get glucose, right? So brain is the main reason why all these things are happening. So there can be other ways of producing glucose from new source, okay? From new source. And these sources can be lipids, can be amino acids, right? Amino acids. Now, concerning our question, let's pay attention to the lipids, because most of the times it's the lipid that it will start from. Because when we have excess glucose, even after the liver has taken some to form glycogen, still if there are excess, the excess will be used to form lipids, and it will be stored as triglycerides. Okay? It will be formed as triglycerides. That's the body fat. That makes us fat. So whenever you don't eat for some time, glycogen is converted to glucose. But if glycogen store has been depleted, then we still need glucose for the brain. So glucose will be produced from new sources. And the process of producing glucose from new sources is called gluconeogenesis, right? Gluconeogenesis. Now, most of the times it's from the lipids, amino acid, and some other stuff, right? So let's take the lipid, for instance. So the lipid is usually having a glycerol backbone, glycerol, and this one is 5 fatty acids, right? So normally this glycerol will be broken away from the fatty acid, and we will have these 3 fatty acids roaming about in the blood. Then this glycerol will be used to convert, or will be used to produce glucose. Now it's left with this fatty acid. This fatty acid will have to be sent to the liver, and in the liver, it will undergo a process called beta oxidation, okay? All right, so it will undergo a process called beta oxidation. And once it undergoes beta oxidation, what will happen? We will produce excess acetyl-CoA, okay, acetyl-CoA, and we can produce a lot of FADH2 and NADH, right? These substances ideally will be sent to the mitochondria to produce some sort of energy. But we have excess what? Acetyl-CoA. Ideally, if there is oxaloacetate, this acetyl-CoA should go into Krebs cycle, but there is no oxaloacetate. So what will happen is that acetyl-CoA will come together, okay? They will come together to form ketone bodies. They will add a lot, acetyl-CoA will be coming together to form what we call ketone bodies. Now, these ketone bodies are acidic in nature. They are acidic in nature. So what is going to happen is that even though the ketone bodies are going to serve as a source of energy, but because they are acidic in nature, they will push the blood pH low, and the body will move into a state of what? Acidosis. Okay? Acidosis. So remember, I just used in a state where you are hungry, okay, you've eaten. When you eat, excess glucose will be stored as glycogen. Glycogen, once you are not eating for some hours, it will be released back as glucose and the brain will use it. Once the brain finishes using it and still the brain needs glucose, then the body will start producing glucose from lipids and amino acids. So we took only lipid. And we said that the lipid will start breaking down. The glycerol part will be used to produce new glucose. And then once the glycerol is used to produce glucose, this free fatty acids will now undergo a process called beta oxidation. Then it will produce excess acetyl-CoA, FADH2, NADH. These ones will go into the electron transport chain. But then the acetyl-CoA here will come together and then form what we call ketone bodies. And these ketone bodies, even though serves as a source of energy, still it is acidic in nature, so the body will go into a state of what? Acidosis. Now listen, for those people who have diabetes, please pay attention. Those people who have diabetes mellitus, we can have two types. We have the type 1 and the type 2. Okay, so the type 1 people are those who are not producing insulin at all. So if you are not producing insulin at all, it means that the body cannot use the glucose. Which part of the body? Especially your muscles and the fat cells or adipocytes, okay? The fat cells, adipocytes, okay? So in diabetes, either type 1 or type 2. So in the type 1, you are not producing insulin. In the type 2, either the insulin is produced, but the body still, the receptors are not active, or you can have these two situations whereby the body is still not producing enough insulin, plus the receptors too are not active. So basically what is going to happen is that when you finish eating in diabetes, now listen, I'm explaining the diabetes. When you finish eating, the brain will make use of its own glucose. Listen, after the brain has made good use of its own glucose, even though the liver will store some as glycogen, but chunk of the glucose that will be in the blood would have to be used by the adipose tissue. Remember we said that extra excess of the glucose will be used to form triglycerides. That is where the adipose tissue will come in. And most of it will go into the muscles. So it means that if we have excess glucose in our blood, the liver will store its own. But this process of triglyceride formation occurring will not occur. Or muscles using the glucose will not also occur. So after the liver has stored the amount of glucose that it can store, the rest will still remain in the blood. So in diabetes, the patient's sugar will still be high in the blood, okay? But you know one funny thing? Because the muscles and adipocytes are not getting the glucose, they are starving. So we call it starvation in the midst of plenty. There is more glucose in the blood, but they cannot take the glucose. So because they cannot take the glucose, there is a signal from these muscles and adipocytes which will activate this process whereby the stored or the little stored fat here will start breaking down to go through the process of gluconeogenesis, thinking that there is no glucose in the blood. So there will be activation of gluconeogenesis, even though still there is a lot of glucose in the blood. In people with diabetes, you see, more glucose in the blood, still gluconeogenesis has been activated. So once gluconeogenesis is activated, there will be excess production of, glycerol will be used to produce new glucose. Fatty acid will go through beta oxidation. More acetyl-CoA will be produced. More ketone bodies will be produced. That is the problem with people with diabetes. And if someone is having diabetes and this gluconeogenic pathway has been activated, and then it has led to the production of excess ketone bodies, that is what we call DKA, diabetic ketoacidosis. Okay? So in the question, they are saying someone is having diabetes and it has led to excess production of acid into the blood, or maybe lower blood pH. What product has led to the lowering of the blood pH or the acidosis? And the product that will lead to the lowering of the blood pH is the ketone bodies. Does anybody have any question? I hope you understand it.
Yes, please.
All right, so let's move on to the next question. Does anybody have any question?
No, please.
All right. So, where is the question? So, patients who suffer from severe diabetes and don't receive insulin after metabolic acidosis have metabolic acidosis. This is caused by increased concentration of the following metabolites, and the answer is going to be D, ketone bodies. So, Monica, can you please read question number 9 for us?
Yeah. A 62-year-old woman complains of frequent pain attacks in the area of her chest and backbone, rib fractures. Her doctor suspected myeloma, that is called a plasmacytoma. What of the following laboratory characteristics will be of the greater diagnostic importance?
Okay, so ideally in the bone marrow, it is the small bone, the flat bones that usually produce.
Dr. Mo.
Yes, sir.
Please, I'm sorry. I wanted to ask a question concerning the diabetic aspect. So please, I want to know if the ketone bodies, can it cross the brain memory? The
ketone bodies will do what?
Can it cross the brain memory?
Yes, it can.
Okay.
Yeah, it can.
Like how the glucose can also cross to feed the brain. Like how the glucose can also cross the brain memory.
Glucose is having a glucose transporter in the brain. We call it glucose transporter 1.
Oh.
You understand? So they are just different pathways. Okay.
Okay.
Yeah, but that you can have this thing. So let's move on to the next question. So this question, please, a bigger screen, please. A bigger screen, please. So
that is blur. We can't see properly.
You can't see it. Can you see it now?
No, please.
Okay, let me draw something, then I'll try to work on it. So normally, but you can hear me. Normally, it's in the bone marrow that we produce the blood cells. Okay, an example of blood cell is the plasma cell. And the plasma cell, its activity is to produce antibodies. So B lymphocytes will be differentiated into plasma cells, and it will start producing antibodies to fight against infection. However, there are situations whereby this plasma cell is being produced abnormally. Okay, so there is excess production of those plasma cells in the bone marrow. And once there is excess production of that abnormal plasma cell, remember I said the plasma cell produces what? Antibodies, right? Can you see it now? Still.
Okay, it's fine now.
It's fine now.
Yeah.
Oh, it's not okay.
It's not okay. It's not okay.
It's very okay. It's very okay.
All right. So in the bone marrow, there is production of plasma cells. The plasma cells' activity is to produce antibodies. Now, there can be something which will go wrong, and then there is excess production of what? Plasma cells. And these plasma cells will occupy all the bone marrow so that it will use all the nutrients. It will use every available resource just to produce more plasma cells. Okay, and these plasma cells are going to produce some kind of antibodies. Okay, these antibodies that they are producing, you know, normal antibodies are what? Having a light chain. This is the heavy chain, right? It is having a heavy chain and a light chain. Okay, the light chain is connected to the heavy chain through disulfide bond, right? Yes, like that. But you see, in the normal one, this is how the antibodies produce. In the normal plasma cells, this is the normal antibodies that it produces. But in a situation where there is excess production of plasma cells, abnormal plasma cells, listen, abnormal plasma cells, they also produce abnormal antibodies. And these antibodies are just light chain antibodies, okay? And these type of antibodies are called paraproteins. Now, when you see these antibodies in the urine, okay, we call it Benz-Jones proteins. Okay, now listen, they call it, this condition is called myeloma. When it occurs in multiple bone marrow, we call it multiple myeloma. Okay, multiple myeloma. Now look at the way they are occupying the bone marrow. It means that they can even occupy the bone marrow, then destroy the bone itself. Okay, so whilst they are destroying, they release a lot of calcium, and also there will be what? Some lytic, they can be fractures of the bones, and then they can also lead to pain in the bone. Okay, so once it occurs in a lot of bone marrow, we call it multiple myeloma. But if it forms like a tumor in the bone marrow alone, that's what we call the plasmacytoma. Okay, plasmacytoma. So multiple myeloma is basically a tumor of the bone marrow leading to excess production of abnormal plasma cells. And these plasma cells also lead to the production of abnormal antibodies called paraproteins. And these antibodies can be seen in the urine as what we call the Benz-Jones proteins. Okay, does anybody have any question? All right, so let's answer it and move on, please. So the patient will experience some bone pain, fractures, and stuff like that. And obviously, because the other cell lineage are not getting the opportunity to also grow well, there will be what? Suppression of those cell lineage. Can you please fill the question and let's move on. So in this case, there will be low production of white blood cells, low production of red blood cells, and other important blood cells like the platelet. And this patient will experience multiple infections. So in this case, the patient, they are saying that a 62-year-old woman complains of frequent pain attacks in the area of her chest and backbone, rib fractures. Her doctor suspected myeloma. What of the following laboratory characteristics will be of the greatest diagnostic importance? And it will be what? Paraprotein. But next time, when you don't see paraprotein and see Benz-Jones protein, it is the same thing. So let's move on to the next question, please. Priscilla, can you please read the question number for us?
Okay, question number 10. A 2-year-old child had an acute respiratory viral infection and died.
I can't hear you.
Can you hear me?
Can you hear Priscilla?
Can you hear me?
Okay.
No.
Can you hear me now, please?
Hello. Hello.
Yep.
Priscilla, we can hear you now. Read.
Okay. A 2-year-old child had an acute respiratory viral infection and died from cardiopulmonary decomposition. Autopsy revealed that his right lung was hyperemic in the second, sixth, and 10th segment, and on the insertion there were airlines, yellowish, foxy of irregular form, from several millimeters up to 1 centimeter large. Microscopy examination revealed exudates consisting mainly of neutrophils in the given areas of pulmonary tissue in the alveoli, bronchioles, and bronchial tube. What is the most properly diagnosis?
Okay, so this one, I'm just going to give you a clue. Okay, when we say focal pneumonia is basically a type of pneumonia where there is damage into multiple lobes. Okay, a focus in multiple lobes. Now, you know, for instance, the right lung is having how many lobes? 3, right? That's the upper lobe and the middle lobe and the what? The lower lobe. The upper lobe is having 3 segments, right? This one is having 2, and this one is having 5. The lower lobe is having 5. So when they say the second segment, it means the second segment is found in the what? In the upper lobe, right? The 6th segment and I think the 10th segment, they are all found in the lower lobe. So first of all, when you see a question like this and you are describing maybe inflammatory process going on in the alveoli and the bronchioles and stuff like that, and they tell you that there are multiple segments involved, like the 6th, the 2nd, the 6th, and the 10th, then please just go straight and think of what? Focal pneumonia. Because if it is occurring in one lobe, it usually presents as a lobar pneumonia or Krupus pneumonia. Okay? Krupus pneumonia. I hope you understand it.
Please repeat that one again.
What I'm saying is that...
No, about the lobar. Only lobar.
So the lobar pneumonia, it is when a particular lobe is affected. Okay? Most of the times, lobar pneumonia and Krupus pneumonia, like, they overlap because there is formation of fibrin, which will occlude the bronchus or the bronchioles, supplying that lobe, okay? And the whole lobe will not have air getting in there, okay? So that is what we call lobar pneumonia, and it occurs in one particular lobe. But then when you have some kind of pneumonia occurring in different lobes at different segments, okay, it's what we call focal pneumonia. All right, so let me, do you understand it now?
Yes, please.
All right.
Does
anybody have any questions? So the clue there is look for segments, okay? And is the segment found within the same lobe or it is found at different lobes, okay? The upper lobe is having 3 segments. The middle lobe is having 2 segments, making it 5. And the lower lobe is having 5 segments. That is the right lung, okay? So it gives us 10 lobes. Does anybody have any question?
No, please.
Okay, so let's move on to the next question. So Ruth, can you please read question number 11 for us?
Okay, autopsy of a 17-year-old girl who died from pulmonary failure revealed a small of caseous necrosis in the inferior lobe of the right lung, an occurrence of cases, necrosis in the bronchopulmonary, bronchial, and biofunctional lymph nodes. What is the most probable post-mortem diagnosis?
All right, so please give me a bigger screen. See, in people who are having this thing, tuberculosis, okay, there are basically two forms of tuberculosis, okay. We have the primary tuberculosis and we have the secondary tuberculosis, okay. And I'm going to talk about the primary tuberculosis and maybe something small about the secondary. So, thoracic. So, first of all, in primary tuberculosis, it occurs in younger age people. That's the first time they are being exposed to the this thing, Mycobacterium tuberculosis. So usually those people, they are young, okay, below 20, 21, thereabout, okay, below 21. So first of all, if they give you the question, look at the age of the patient. If it's talking about tuberculosis, look at the age of the patient. If the patient's age is below 21, think of primary tuberculosis. It doesn't matter how many things that they are talking about. Still think of, let primary tuberculosis be part of your differentials. Now, under that primary tuberculosis, we have three different forms. We have the primary tuberculous intoxication. This type of primary tuberculosis, all that they present is some flu form, some high temperature and stuff like that. There is no specific focal degeneration, okay? But so it means that here it can present like different form of diseases. You may not even think that it is even tuberculosis. So that's the primary tuberculous intoxication. But we have a primary tuberculous complex. In this complex form, they usually form granulomas, okay? In the granulomas, in the lungs, okay? And sometimes there is caseous necrosis, okay? But in the lungs, where specifically you can locate this primary tuberculous complex, is usually at the bifurcation of the bronchus, okay? So you can see this, the complex can be here, the complex can be here, the complex can be there.
We
okay?
cannot see down there.
We can't see what you're writing. Go back.
Sorry. Can you see it now?
Yes, sir.
Yes. Thank you.
Okay, so assuming this is the trachea and these are the bronchus. For the primary tuberculous complex, it can be here, it can be there, it can be there, okay? So and that complex is a granuloma, and sometimes you see some caseous necrosis going on there, right? And the intrathoracic lymph node diseases, that one, they will cause enlargement of the thoracic lymph node with caseous necrosis. Usually the two cannot easily be differentiated, okay? So once the patient's age is 17, please first think of what? Primary TB, okay? Primary TB. And these are the only three forms of primary tuberculosis. If you see anything having primary tuberculosis attached to it, apart from these three, it is not primary tuberculosis. You see that hematogenous what? It is a disseminated form of tuberculosis. That disseminated form of tuberculosis is a secondary tuberculosis. So in the secondary tuberculosis, these are people who had the primary tuberculosis, and due to strong immunity, the tuberculosis was suppressed, okay? And maybe along the way, they contracted their immune system was lowered, and there has been reactivation of the old tuberculosis. That is what we call secondary tuberculosis. Or the person had the tuberculosis, the primary tuberculosis, and was treated, and the person is now having a reinfection. It forms part of the secondary tuberculosis. And in the secondary tuberculosis, we have so many types. That is where you can have the disseminated form of the tuberculosis, where we can have the hematogenous way of dissemination or lymphogenous way of dissemination. We can also have the miliary, okay? We can have miliary TB. So once you see miliary TB, think of what? Secondary. When you see caseous pneumonia, this caseous pneumonia is very fatal. It can lead to death in no time. Caseous pneumonia is a secondary form of tuberculosis. When you see tuberculoma, is still what? Secondary tuberculosis, okay? So I'm just giving you an idea that these miliary disseminated caseous pneumonia tuberculoma, they are all secondary tuberculosis. But in the primary tuberculosis, we have only primary tuberculous intoxication, primary tuberculous complex, and intrathoracic lymph node infiltrations. And their age is usually below 21. Okay? So once they bring, and usually they will not bring primary tuberculosis and bring any of these. Either they bring one of these and they don't bring the primary tuberculosis, or they will bring only primary TB. Now let's read the question. Does anybody have any question?
No, please.
All right. Please, let's read the question. So, autopsy of a 17-year-old who died from pulmonary failure revealed a small area of caseous necrosis in the inferior lobe of the right lung, and occurrence of caseous necrosis in the bronchopulmonary, bronchial, and bifurcational lymph nodes. What is the most probable post-mortem diagnosis? So what I'm saying is that homogeneous progression of primary tuberculosis doesn't usually occur. It occurs in secondary. So the answer is basically going to be what? Primary tuberculosis. The rest all are what? Secondary tuberculosis. Okay? So the answer is going to be E, primary tuberculosis. And always remember the age. Please, let's move on to the next question. So who haven't read? Nanaya, please, can you read the question number 12 for us?
Okay. People adapted to high external temperatures have such peculiarity. Profuse sweating isn't accompanied by loss of large volumes of sodium chloride. This is caused by the effect of the following hormone upon the perspiratory glands.
All right, so please look here. There is a structure on top of the kidney. What's the name of that structure? What's the name of it?
Adrenal glands.
We cannot see the board.
You can't see the board.
I think you should set your camera to a normal setting.
Oh, where do I have to cut the camera?
Yeah, the camera. Fine.
Is it working now?
Yeah, it's working.
So the middle of that structure is called what? Adrenal medulla. And the outer part here is called what?
Cortex.
The cortex produces 3 hormones, okay? They are what? Aldosterone, right? Aldosterone. Now let's talk about aldosterone. And it also produces what? Cortisol, right? And it produces androgen. But let's talk about aldosterone. Aldosterone is produced by, you know, the adrenal cortex is having 3 layers, right? So remember GFR, okay? GFR. So the G stands for glomerulosa, okay? Glomerulosa. And it's the glomerulosa that produces the aldosterone, right? The S stands for what? Fasciculata. And it's a fasciculata that produces what?
Cortisol.
And the R stands for what? Reticularis. Even though the fasciculata can also produce some androgens, but basically it's the cortisol. The reticularis produces what? Androgens, right? Now, we are going to base this thing on the aldosterone alone. Usually the aldosterone is produced when we have excess production of angiotensin 2. Angiotensin 2, right? Angiotensin 2. When does angiotensin 2 produce a lot? When there is what? Lowered blood pressure. Okay, let's take this one alone. Or maybe high potassium level or stuff like that. But lowered blood pressure will lead to a series of reactions that will lead to production of angiotensin 2. And angiotensin 2 is having its receptors on the glomerulosa. So once it's stimulated, it will produce aldosterone, right? Now, once this aldosterone is produced, one reason why angiotensin II is produced is because of loss of what? Low sodium, okay? Low sodium. So once this aldosterone is produced, this aldosterone again will come to the kidney, okay? Specifically, the kidney's distal convoluted tube, okay? It will come to the distal convoluted tube. And over there, what it will do is that it will tell the cells over there that, look, there is low sodium. So please, let me reabsorb sodium and get away potassium. So normally potassium will be high. So here, aldosterone will come here. Okay, and cause what? Reabsorption of what? Sodium. And wherever sodium go, water will follow. Okay, and water. And then it will cause excretion of what? Potassium. Excretion of potassium. Okay, so if aldosterone is produced, there will be reabsorption of sodium and water, and what will go out? Potassium. No, now on the sweat glands, we have a lot of what? Receptors for aldosterone over there too. So the same mechanism occurs over there. Once aldosterone is released, it will get to the sweat glands, and at that point, there will be reabsorption of what? Sodium. Okay? There will be reabsorption of what? Sodium. So in people who stay in a high temperature zone, when they are sweating, okay, the sweat that is coming out doesn't contain a lot of sodium, because if it contains a lot of sodium, hey, move your thing from here. If it contains a lot of sodium, it means that the body is going to lose a lot of that sodium, the salt, okay? And we will go into a state of what? Hyponatremia. And this hyponatremia can cause a lot of neurological dysfunctions, okay? So that is why people living in high temperature area, there is excess production of what? Aldosterone. Like I told you, aldosterone production is because either there is low blood pressure or low sodium content in blood or high potassium level. So in people living at a high temperature area, there is excess production of aldosterone, and this aldosterone can work on the sweat glands to reduce the excess excretion of sodium. So reabsorption of sodium will work there. Does anybody have any question? All right, so let's move on to the next question, please. The one using Galaxy A6 Plus. Please, can you read the next? So the question that we read, the answer is going to be aldosterone. So who is using Galaxy A6 Plus? Else, James, read question number 13 for us.
Okay, question number 13. I read. An experimental animal that was kept on protein-free diet developed fatty liver infiltration, in particular as a result of deficiency of methylating agents. This is caused by disturbed generation of the following metabolites.
All right. So in the liver, normally in the body, there are certain substances that either the body produces or we take it in, okay, as an essential nutrient. And it helps in the process of exportation of fat from the liver. Okay, exportation of fat from the liver. Now, what is happening is that if we lack those substances, there will be more fat getting into the liver, and this fat will cause what? Fatty liver disease. okay, fatty liver disease. So if we lack those nutrients are usually called lipotropic.
The board is blurred.
Oh, sorry.
It's okay.
Is it clear now?
Yeah.
Okay. So because we have lots of fat in our body, there are certain nutrients that help in preventing this fat from depositing in the liver. And those substances are called lipotropic substances, okay?
Please, I lost concentration. Can you please start all over again?
What I'm saying is that we have a lot, normally we produce, our body will use different mechanisms to produce various forms of fatty acids, right? And these fatty acids, that the liver has to protect itself from the deposition of fatty acid and fat in the liver, okay? So there are a lot of mechanisms that the body uses to avoid deposition of fat in the liver. Deposition of fat in the liver will lead to what we call fatty liver disease, or it can also lead to cirrhosis. Now, these substances, called lipotropic substances, what they do is that they export fat from the liver, okay? So that this fatty liver disease will not occur. They do so by a methylation process, okay? So they donate a methylating group to, in that process of conveying fat from the liver, okay? And those substances are called lipotropic substances. Example of such substance is choline, okay? There are a lot of them. We have another one called inositol, okay? And since we are talking about methylating products, you should remember our methionine. In fact, you see, methionine actually is not what actually plays a role here. But methionine donates its methylating part, or the methyl part, to choline. And the choline is the lipotropic substance. Okay? So methionine technically is not part of this lipotropic substance. So this choline and inositol, their function is to carry fatty acids away, or fat away from the liver, so that it can be used for energy elsewhere in the body. I hope you understand it.
Yes.
So lipotropic substances are just substances that export fat from the liver and prevent fatty liver diseases. So let's read the question and answer it, please. Does anybody have any question?
Uncle,
yes, sir.
Please, I didn't get the explanation on the methionine.
Methionine.
Yes, please.
The methionine donates a methyl group, okay? Methyl group. It donates methyl group, okay? The methyl group to choline.
Okay.
Okay? So when it donates that methyl group to choline, it's that methyl group that the choline will donate to the liver, so that the process of exporting fat and lipids from the liver will occur.
Okay.
Do you understand it now?
Yes.
Dr. Mo, please, so if I understand what you said, for the liver not to become fat, you will need lipotropic substances. And
yes,
example of these lipotropic substances are the choline and the inositol, right?
Yes.
But the methionine can also be fat, but the methionine donates its methyl group to the choline, and this choline will also donate the methyl group, the methyl attached to the choline to help in the transportation of the fat from the liver.
Exactly. Because you see, we have essential and non-essential. You understand? So in this case, methionine will become kind of semi-essential, because it's not methionine that we actually need. We need choline. But choline formation, we need methionine. You get a point? So that's why I said you cannot say it's a lipotropic, because it doesn't directly play a role in that lipotropic activity. You understand?
Yeah, it's very clear. Yes.
Okay, thank you. Okay, let's move on to the next question. So, Gloria, you read the next question for us. Just a moment. I'll be back. Are settling down, okay? So you have the red blood cells and the other stuff, the red blood cells settling down like that, okay? So first you took a blood and it was in the tube, okay? And you spin it for some time and the red blood cell will settle down. And then we'll have the white blood cells forming a fluffy coat, okay? We'll form a fluffy coat here. Okay, and then we'll have our plasma on top, like that. Okay, so assuming this gives us 100, okay, this tube gives us 100% or whatever, you realize that about 45% of it, okay, is the what? Is the red blood cell, and that is called the hematocrit, okay? It's called the hematocrit. Now, the rest here will be the plasma. So what you are saying is that this is for a normal patient, right? This is for a normal patient. Now they are saying that this same normal patient started exercising and then was exercising in a high temperature area, and obviously the patient will sweat, right? When you are sweating, you see the plasma here. The plasma is made up of water, okay, proteins. It's made up of some ions and stuff like that. And the water part here, okay, if you sweat, the water here will go and replace wherever the water left through the sweat. So the water part in the plasma will leave, okay? Now, if the water part of the plasma will leave, it means that the plasma part here, which was probably 55%, will now further decrease, right? So if you take the person's blood again, you took it up to the 100% level again, okay? Because water has left here, you realize that now this blood that you took is going to have more of the, this blood that you took is going to have more of the red blood cells settling down, okay, and occupying about 50% of the total volume, and the rest will be the plasma, okay? The one on top will be the plasma, okay? And now the plasma will be 50, because now you've lost water. You lost water, but the same amount of blood, if you took 100 ml, is the same 100 ml that you took. That is why in this 100 ml, then it means that the red blood cell have to come and replace the water lost, okay? So probably the water loss was making the 5%, but now the red blood cell have to replace that 5%. That's how come the hematocrit became 50 here, okay? Now, what does that mean? It means that the more you lose water, the more your hematocrit also increases, right? The more you gain water, the more your hematocrit will what? Decrease. So when you lose more water, hematocrit will what? Increase. When you gain more water, hematocrit will what? Decrease. So those hemodilution and stuff like that. So I hope this one explains the hematocrit and why when you sweat a lot, hematocrit will increase. So does anybody have any question? Okay, so please project the question, let's answer and move on.
So,
yes, sir.
So can this also be related to people who normally get burns also normally have the high hematocrit?
Obviously, when someone undergoes burns or experiences burns, the person even loses more water, right? The person will lose a lot of water because the skin actually is supposed to insulate our body so that we don't lose water. So once there is break in the continuity of the skin, you lose more water. In fact, not only water. In burns, you also lose a lot of proteins, right?
Yep.
And in that case, the plasma will further reduce more, and your hematocrit will obviously go high, right? All right. Can we please move on to the next question? So here the answer is going to be water loss in the sweat, right? Because the patient was sweating, that was the water that he lost through the sweat that led to increase in the hematocrit, okay? Does anybody have any question? All right, so please let's move on.
I want to read this question.
Read it.
It is simple for me. Examination of a patient.
Please go on.
Examination of a patient with impaired blood coagulation revealed thrombosis of a branch of inferior mesenteric artery. What bowel segment is damaged?
Okay, so you see, basically the answer you know, okay, but then I believe that when you even know the anatomy, there is no problem going over it again, right? So this is how our abdominal aorta looks like. Normally, it enters into the abdomen at the level of T12, right? And at the level of L1, there is an anterior branch. At the level of L2, there is another anterior branch. And at the level of L3, below the level of L3, there is another anterior branch. So this is the abdominal aorta. So remember, from the heart, there is what? Aortic arc. Then it will go down as the descending aorta and into the abdominal aorta like that. Now in the abdomen, okay, we have anterior branches and we have lateral branches. The anterior branches are the ones that supply the GIT. And remember that your GIT, we have the foregut, right? We have foregut. Who knows where the level at which the foregut ends? We have the what? Midgut, right? Who can tell me the level at which the foregut ends? And where does the midgut also end? And where does the hindgut end? So, and the hindgut. So the structures that are found in the foregut are the stomach.
Are we all seeing the video?
No.
No.
You can't see it. Sorry, sorry, I'm sorry. It's from my end here. Can you see it now?
Yes.
All right. Thank you. So the foregut here is supplied by the anterior branch coming from the level of L1. And this branch of blood vessel is called the celiac trunk, right? That one supplies the stomach, the abdominal part of the esophagus, supplies part of the duodenum up to the level of the major papillary. Okay? Major papillary. That's where the what do we call it? The common bile duct and the pancreatic duct opening into the duodenum. That is where the foregut ends. So it supplies the spleen, the pancreas, and then the liver also, the celiac trunk. Then there is a second one called superior mesenteric artery. That supplies the midgut. And the midgut starts from that major papillary up to 2/3 of the transverse column. So that is the midgut. And the hindgut, this is what we are talking about. The inferior mesenteric artery. That one supplies the rest of, or the last 1/3 of the transverse colon, okay, or the descending colon, okay, descending colon, the sigmoid colon, and superior rectum, okay, rectum, okay. So that is how, can you please see the board?
Yes, please.
All right. So what I'm trying to say is that the abdominal artery is having 3 anterior branches, and these anterior branches supply the GIT. We have the celiac trunk, which supply the foregut, and we mentioned the structures over there. We have the superior mesenteric artery, which supplies the midgut, and we mentioned that it starts from the level of the major papillary up to 2/3 of the transverse, the first 2/3 of the transverse column. Then we have the inferior mesenteric artery, which supplies the hindgut, and it supplies the hindguts are the last 1/3 of the transverse colon, the descending colon, the sigmoid colon, and the rectum. Okay, why am I mentioning all this? So because here the answer, they brought the sigmoid colon, but next time they may not bring the sigmoid colon. So you need to know all the structures here, right? And like I said, the midgut here, it means that it supplies part of the duodenum, the jejunum, the ileum, the appendix, the cecum, the ascending colon, the transverse colon, up to 2/3 of the transverse colon, the beginning. And the foregut here supplies the stomach part of the esophagus, the stomach itself, and the duodenum up to the level of the major papillary. And the accessory structures like the pancreas, the spleen, the gallbladder, and the liver, okay? Does anybody have any question? So,
Dr. Mo,
yes, please.
in the options, there's colon transversal.
That's why I'm saying that, look, I labeled it. I said that the last 1/3 of the transverse colon. So if they bring colon transversal and they are not saying 1/3 or 2/3, you still don't have to choose that one. Okay? I'm just trying to let you understand the specifics. The superior mesenteric artery supplies the transverse colon. The inferior mesenteric artery also supplies the transverse colon. You get the point. But with the superior mesenteric artery, it supplies the first 2/3 of the transverse colon. Okay? The transverse colon. So this is, let me draw the colon here, right? All right, so this is how the stomach is. So see, this is just, okay, ileum. The superior mesenteric will supply all the ileum, okay, all the ileum, the jejunum, okay, and then once you, this is the, listen, the duodenum, and let's just assume, I'm just drawing something like the stomach here, okay? Let's assume this one is a major papillary. From this level here, coming down, supplying all these parts up to 2/3 here. All this area is supplied by superior mesenteric. But you see, this part here, which forms about 1/3 of the transverse column, is still supplied by a branch of the inferior mesenteric artery, which is called the ascending, because there is a left colic branch coming from the inferior mesenteric, and it divides into ascending branch and descending branch. And that one, the ascending branch here, will go and meet with a middle colic artery coming from the superior mesenteric. Okay? So what I'm trying to let you understand is that this whole transverse column is supplied by both the superior mesenteric and the inferior mesenteric. Okay? But if the question is asking for what structure, and you want to single out a particular structure that strictly is supplied by the inferior mesenteric, please talk about the descending column, the sigmoid column, and the superior part of the rectum. You understand it?
Yep. Yes.
Okay. All right, so let's move on to the next question. So the answer is going to be sigmoidum, right?
Yeah.
Okay.
Dr. Mo.
Yes, sir.
I want to be clear with what you said. So if you may, and engage me a little.
All right.
So you said that without showing the screen, you said that no, please close the screen. I want to be sure of what I am saying. Very well. So I want to be sure. What you are saying is that the celiac trunk will supply the esophageal part of the stomach up to the major papillary, right? And then the superior mesenteric artery will supply from the major papillary to 2/3 of the transverse colon transversum, right?
Yes,
and then
please.
The remaining 1/3 of the colon transversum down to the rectum will be supplied by the inferior mesenteric artery.
Yes, please.
Very well. Which includes the sigmoid, the descending column, the descending column, and then the rectal whatever.
The rectum, yeah.
Thank you.
Okay, you're welcome. But the celiac branch also supplies the gallbladder, the liver, the pancreas.
The accessories, the other accessories.
Okay, thank you. So let's move on. So question number 16. Let me also read some. A 42-year-old woman with neuralgia of trifacial nerve. That is a trigeminal nerve, okay? The trifacial nerve they are talking about is the trigeminal nerve. Complains about periodical reddening of the right part of her face and neck. Sense of warm gush, increased skin sensitivity. These effects can be explained by the following type of arterial hyperemia. First of all, one thing I want you to understand is that whenever there is sympathetic activity, most of the blood vessels of the skin will constrict, except the facial vessels. When there is sympathetic activity in the facial vessels, they will dilate. That is why fair people blush. Okay, so when you stimulate the sympathetic nervous system, instead of whilst the other part of the body blood vessels or the skin blood vessels are constricting, only the facial vessels will dilate. Okay, so that is how come this patient faces having a redness and stuff like that. Now, they are saying that the person is having neuralgia. Neuralgia is a type of pain as a result of maybe a problem with the nerve, okay? So maybe there is some problem with the nerve that is sending excess impulses to the brain and it is causing some pain, okay? And that means that the nerve is overly stimulated. So if the nerve is overly stimulated, it means that the nerve, this is a sympathetic nerve, which is being overly stimulated. because it's supplying structures like the vessels, okay? And you know, the vessels and some internal organs are supplied by the sympathetic, the autonomic nervous system, right? So something like the vessels. So the vessel being dilated here, it means that the sympathetic nerve has been stimulated. And once it is stimulated, it means that the tone has increased, okay? So in this case, once you stimulate it, we call it neurotonic. But once you destroy the nerve activity, it's called neuroparalytic, okay? So in this case, the patient face is having redness, warm gushes, and blah, 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 those things. It is because there is what? Stimulation of the nerves supplying the blood vessels of the face. And that is causing rushing of blood into the vessels and causing redness. And that's hyperemia, right? So this type of hyperemia is due to neurotonic activity. So hyperemia basically means when there is increase in blood flow into some vessels and it is causing some redness, okay? And this type of increase in blood flow is due to neurotonic activity. Does anybody have any problem with the explanation?
So,
okay, so let me draw something here. They have some few questions to answer. So. Okay. So normally this is blood vessel, right? You know the blood vessels, the arteries are having smooth muscles in them, right? I mean, the tunica media, right? And
the screen.
The screen is not clear.
Yes.
Like it's not showing.
Not showing. Oh, okay.
When I was explaining, the screen was there. Okay. So the blood vessels, normally what I'm saying is that most blood vessels, okay, most blood vessels have alpha-1 receptor. These alpha-1 receptors, once stimulated, will cause contraction of the smooth muscles, okay? So that what will happen is that the vessel lumen will what? Will be small. So assuming this is the normal size of the vessel lumen. So this alpha-1, it means that it's an adrenergic receptor. So sympathetic outflow will cause it to be activated. And they'll go at vasoconstriction for most of the vessels supplying the skin. However, the skin of the face alone, it will cause what? Vasodilation. So it means, whilst if I stimulate this receptor here, will cause vasoconstriction somewhere. When I stimulate that same receptors on the face, it will cause vasodilation. Okay? Now, in the question, they are saying that someone was having neuralgia. And I'm saying that neuralgia is a neural fiber condition where there is excess, there is pain due to excess stimulation of the nerve fiber. It's a disorder, okay? Now, when there is excess stimulation of the nerve fibers, it means that we are stimulating the nerve fibers. So if it were to be on the skin, obviously, like I said, on the skin, the vessel would have what? Constricted. But on the face, the vessel will dilate. Okay? The same nerve supplying both the face and the skin. But the vessels of the skin, once that same fiber is stimulated, it will cause vasoconstriction. But on the face, it will cause vasodilation. And I'm saying once you stimulate it, we say that it is neurotonic. Okay? You have increased the tone of the nerve fiber. Okay? If you increase the tone of the nerve fiber, it means that you are stimulating the nerve fiber. So we are talking about hyperemia. Hyperemia too means that when blood vessels become congested with blood, and it is showing as a sign of what? Redness and stuff like that. That is hyperemia. Okay. Now, so we are saying that when the face, when the sorry?
I can't see the screen. I can't see the drawing.
All right, just a moment.
Okay, okay.
It's okay, it's okay.
It's okay now.
Okay. So when in neuralgia, there is increase in nerve tone, that's neurotonic, and it will cause dilation of the facial nerve. And once the facial blood vessels, and once the facial blood vessels become dilated, more blood will rush there, and it will cause hyperemia. So that type of hyperemia is called neurotonic hyperemia. Do you understand it now?
Yes.
Yeah.
Okay, so please let's move on to the next question. Sorry, my battery is low. That's why the screen keeps on going off and off like that. Okay, let me just switch this one. Help me smooth until I finish. All right, so question number 17, who will read it for us? Anybody can read it for us.
I'll read. A 7-year-old child often suffers from strepto, I think it was supposed to be streptococcal angina. Doctor suspected development of rheumatism and administered serological examination. The provisional diagnosis will be most probably confirmed by presence of antibodies to the following streptococcal antigen.
All right, so please screen and let me just explain this one. So, you know, there are a group of bacteria, right? Now, Streptococcus is a gram-positive bacteria. Now, with Streptococcus, we have types. We have the beta hemolyticus, okay? Hemolyticus. Beta Streptococcus, okay? Group A. Now, this particular Streptococcus, once maybe they can cause sore throat, okay? They can cause sore throat. So once you get infected with it, or maybe someone who is prone to rheumatoid conditions, once they get infected with this bacteria, what happens is that this bacteria releases some toxins, okay? They release some toxins called streptolysin. Example of such toxins is streptolysin, okay? So streptolysin O. The O stands for oxygen, okay? So it means that it's oxygen level. In the presence of oxygen, it doesn't work again. So normally, this streptolysin O causes a lot of damaging effects. However, that is not only the problem. The body will start producing some antibodies against this streptolysin O. That is what we call the anti-streptolysin O antibodies, okay? This anti-streptolysin O antibodies, that is where the problem is. Instead of these antibodies attacking only the streptolysin O, these antibodies sometimes can attack various connective tissues, collagen fibers found in the heart, okay, in the joints, okay, and even in our brain, okay, in our brain. So that anti-streptolysin O antibodies, instead of attacking only streptolysin O, which is produced by the streptococcus, it tends to attack some of the collagen fibers found in our heart, and it will cause rheumatic heart disease. When it attacks the joints, then we can get rheumatic arthritis. When it gets into our brain, specifically when it gets to our basal ganglia, then we get some chorea, which we call the sydenham chorea, okay? So in people who are affected by streptococcus and the Streptococcus produce streptolysine O, and the patient is prone to rheumatic diseases, we check for the titer of the anti-streptolysine O antibodies. We check if the patient's blood is having a lot of this ASO, okay? Usually it's around 200, greater than 200 international units. It means that it's too high, and that might be the reason why the patient is having. Then you can confirm that the patient is actually having rheumatoid arthritis or maybe rheumatic fever diseases. Does anybody have any problem? So those people who have rheumatic fever diseases, it is triggered only when the patient gets infected with the beta hemolyticus group, Streptococcus group A, okay? And the body will start producing the anti-streptolysine O against the streptolysine O toxin. And these antibodies will now go out of their way to damage our hearts, the joints, and the brain, and other stuffs. Okay, so let's move on to the question. Let's read it and answer it and then move on. So, 7-year-old, please let me repeat the question. I didn't, okay. 7-year-old child often suffers from streptococcus angina. That is the sore throat that I'm talking about. Doctor suspected development of rheumatism and administered serological examination. The provisional diagnosis will be most probably confirmed by the presence of antibodies to the following streptococcus antigen. And that particular antigen should be what? Streptolysine O. If we see that there is antibodies against the streptolysine O. So the answer is going to be what? O streptolysine, all right? O streptolysine. So question number 18. Monica, please read that one for us. Is Monica there? If Monica is not there, who can read that one?
A clinical diagnosis of a female patient was gonorrhea. What examination method can be applied for confirmation of this diagnosis? Okay, so people who are suffering from gonorrhea, if the person is a male, they will have urethral discharge. There will be some fluid coming from the penis. If the patient is a female, there will be vaginal discharge, okay? So mostly in females, what we do is that what we call the high vaginal swab. So they will take a swab from the vagina, getting close to the cervix, right? And they will use the swab, okay, to detect whether it is gonorrhea or not. So that swab is a contaminated material, right? It's a contaminated material. So in trying to diagnose gonorrhea, you either take a vaginal swab or maybe you take urethral swab of the discharge, then you examine it. So that is called contaminated material, or what we call, can you please move the question up a bit? No, not screen. I said move it up, please.
The pathogenic material.
Yes. So where is the answer? So microscopy of pathological material, okay? Microscopy of pathological material will be the answer. So in gonorrhea, the pathological material is what you use. So let's move on to question number 19. Daphne, can you please read that question for us? Is Daphne there? Is Daniela there?
Sorry, I was reading with the thingy off.
Okay, okay.
A patient staggers and walks astraddle. He has hypomyotonia of arm and leg muscles, staccato speech. In what brain section is this affection localized?
Okay, so just take staccato speech as slurred speech, okay? You know the way some people speak when they are drunk, okay? Like their speech becomes slurred. And the hypomyotonia, like kind of weakness in the muscle. Walking astride is like when you are walking and your buttocks is coming down, okay? It's like the person is walking and it feels like the person wants to sit. Yeah. So these are as a result of uncoordinated muscular activities. Now, in our brain, the other relay center for coordination of muscle activity is the cerebellum. So the cerebellum is the one that communicates with the cerebrum and our basal ganglia. And it tells our cerebrum and basal ganglia whether that muscle has contracted. This muscle is relaxed at this moment, so let's contract it, let's do that, and stuff like that. So it just continuously sends information from our body to our cerebrum, and always keeps on collecting information from the what we call proprioceptive information, where our joints are, whether one muscle is contracting, because before you can achieve a particular movement, one muscle has to contract, another has to relax. Sometimes both have to contract at the same time. But the brain, how does the brain get to know all these things at a go? It is the cerebellum which communicates with the cerebrum, okay? The higher activity, the cerebrum, and tells the cerebrum that now the person wants to do this kind of movement. So you see, the cerebellum even have a pre-collected ideas of the kind of movement that you want to do. That is why some people can achieve some ballistic movement. Ballistic movement, like those people who do this acrobatics. They can roll about how many times I can't even count. It's the cerebellum that has already collected this thing, the kind of movement, and learned that your body can do this thing. So once you start to do it, the cerebellum can send that information at a faster rate that the person is going to land at this time, the person is going to move at this time, and the brain the cortex has to contract, send information for contraction of a particular muscle or relax some particular muscle, so that this kind of fast movement can be achieved. Even when you are writing, some sort of ballistic movement occurs. So it's the cerebellum which helps you in achieving such coordinated activities, okay?
Okay.
So let's move on to the last question for the day. This question is for the lab people.
I want to read it.
Read it and answer it for us. And tell us why.
No.
Thank you.
Read it.
A bacteriological laboratory received sputum sample of a patient suffering from tuberculosis. Bacterioscopic examination of smears and detection of tuberculosis bacillus can be realized by one of enrichment methods that involves processing of sputum only with solution of caustic soda. What is the method called?
Okay, so you see, this question, first of all, they know that the patient is suffering from tuberculosis. So it's not as if they want to check whether the person is suffering from tuberculosis or not. Rather, they want to see this thing. You know, tuberculosis, we can have multi-drug resistance tuberculosis. So they want to isolate the Mycobacterium tuberculosis itself and study it and know that was this one a multi-drug resistant type of tuberculosis or what? Okay, so in the process of doing that, they have to first do homogenization and also add what we call the caustic soda. Actually, the method that they are doing, the name of the method is called modified Petrov's method, okay? But that homogenization is part of the method, okay? And once you are adding the caustic soda, it means that homogenization has already been done. Then caustic soda will be added. Then they can now isolate the Mycobacterium tuberculosis and study it. Okay, so this test is usually done in most of the developing countries where tuberculosis is more rampant. Okay, so you keep it in mind that the moment you see caustic soda, then it means homogenization has to occur also. But when you ask of homogenization basically means that you take a material and in a form of another material, and then basically try to make it the same, like crush it or something like that, to give it the same composition. Okay. So this question is a pure lab question, but the main method is called the modified Petrov's.
Modified Petrov's.
Yeah. Okay. So this brings us to today's edition